Biological reconstruction is something that's very important in paediatric oncology practice, and we're mainly treating osteosarcomas and Ewing sarcomas, but there are, as you've heard, a range of other tumours that need to be managed. There's a distinct predilection for long bones in the pelvis, and in many instances the primary lesion can be juxta-articular, about 75%, and particularly so for osteosarcoma. And our survivorship over the years has improved, but it's been relatively static in the last probably decade, but these patients are long-term survivors. And because they're paediatric patients, we need to consider that in everything we do. So why surgery? Well, it improves the outcomes that are offered by chemotherapy alone, removing the primary focus and controlling local disease, and it manages the underlying compromise of the skeleton. But we all need to consider that oncology management is about preserving life, and I think that's a very important thing. We've got to always talk to the families about preserving life, because sometimes they have a different concept. We next preserve function, and then we have to consider these patients are compromised by the treatment they're being given. We shouldn't be often limb salvage unless we can get clear surgical margins, and the reconstruction will be functionally better both physiologically and psychologically than an amputation. In paediatrics, we have issues with size, not just of the tumour but of our patients, the growth potential of our patients, the longevity of our patients, and the need for revision procedures. So these patients are weakened by poor immunity, nutrition, musculoskeletal health and emotional well-being, and they're high risk for infection, wound breakdown, delayed and non-union, and often they're also at risk of inadequate rehabilitation. So why choose a biological solution? Well, we choose it because with long survival time, children and adolescents potentially outlive a prosthesis. The revision surgery for megaprosthesis is highly complex, as we've just been seen, and at high risk. And biological solutions are generally more robust so long as the joint can be maintained. And a biological solution can be grown, whereas standard prosthetic solutions cannot. And growing prostheses are problematic, not only economically problematic, but they also will require revision eventually. So what are our options that we have? Well, we've got rotation plasty, biological reconstruction, which can be intercalary osteoarticular grafts and bone transports, or non-biological reconstructions with megaprostheses or combined procedures. So if we look at intercalary, which is often what we're doing, this depends on the size of the defect, and it can be either non-vascularised or vascularised graft, and we've tended to use the fibula for most of these. The fibular graft can either be used as a single or a double construct supported by internal fixation, nails and plates that replaces diaphyseal and metaphyseal resected segments. But with these cases, often limb length discrepancy will be common, and that needs to be incorporated into the treatment plan, and stress reactions in the grafts have to be expected. So that's again planning for what might happen in the future. Hypertrophy of such grafts is rapid, and the vascularised grafts union is good, but it's and more readily achieved than non-vascularised. Joint preservation is possible as long as you get clear margins, but we need to recognise that the physis isn't that great barrier that people think it is to tumour, and tumour can often spread through the physis. If you have to resect below the physeal level, then we've got problematic in maintaining the joint because we're losing the blood supply and the ligamentous attachments for joint stability, and you may have to use endoprosthetic reconstruction. So here's an example of a 70-year-old with a periosteal osteosarcoma in the diaphysis. Here's the extent of the lesion, and this is a type of lesion that may not need full chemotherapy treatment. And we will plan these patients out carefully how we're going to reconstruct them with adequate fixation. In this case, I use an external fixation to stabilise the limb to do the resection, and then using a fibular graft which will rapidly incorporate. And that's a relatively straightforward reconstruction to do for a tumour that's relatively easily resected. But what about if we have tumours that have greater extent, such as this Ewing sarcoma of the distal femur with a large soft tissue mass, where there is extent of the tumour beyond the margins that you can see here, with a PET scan showing quite considerable activity in a high-grade tumour. These patients can be reconstructed using a combination of internal and external fixation and an A-frame type fibula. The area of concern is always the cortical junction, which can be slow to heal, but with local graft and attention to that, we can get good stability and reconstruction. But there is a problem with this reconstruction in that the patient will have some shortening. Here's another intercalary reconstruction, a 7-year-old with a Ewing sarcoma of the humerus, extended right up to the physeal plate, and the resection was done at that level. Here's the resection with some K-wires to maintain orientation. with a reconstruction initially done with a plate. The radial nerve had to be sacrificed in this case, and there's the bony reconstruction without the graft in place, with good stability achieved. Fibular graft with a cable graft to the nerve, for the radial nerve, and that's the reconstruction, and this patient ended up with good function at the end with a recovery of the radial nerve. When we sometimes have to do osteoarticular reconstructions, there are a number of free tissue transfers that can be used. We can use free toe transfers for small joint reconstruction, and the fibular head has been one of our great reconstructive options for articular cartilage reconstructions. So here's an 8-year-old with a Ewing sarcoma of the first metatarsal. In many centres this might be dealt with an amputation, but if we can get clear margins, we can do a free toe transfer using tissue from the opposite side to reconstruct that joint and re-anastomose that across to the other side, because the great toe preservation is important for function. And this is what it looks like at the end, and it's a cosmetically acceptable result even though we've sacrificed a toe from the other side. And the match, surprisingly, can be quite good, and the hypertrophy of that graft is normally good. What about a 4-year-old with an osteosarcoma of the proximal humerus? In this case, we've had to sacrifice the joint. We need an osteoarticular reconstruction. There's the resected segment from the humeral head down to the condylar flare. With a nice combination between those surgeons who do limb reconstruction and tumours means we're quite happy putting frames in various positions in these cases. And here's a free fibular graft with the fibular head. That's the reconstruction. There's the resected fibula. And this is using the fibular head as an articular reconstruction there. Now, sometimes this works, sometimes it doesn't. In this case, the patient developed acute arthrosis through the physis. That didn't matter because functionally this patient ended up with a good result and good stability. And here's the functional outcome of that patient, although they have, in this case, the radial nerve was sacrificed and regrafted, but the function hasn't been as good in the hand. This is another case of how we can use the articular surface in the fibula. This is an osteosarcoma of the radius. And again, this is a free fibula with a paddle. The resection's been performed and the reconstruction's been done. It's stabilised with plate and external fixation. And the radial head can actually be, the fibular head can be a good match at the wrist. Combination of plating, and this is what it looks after reconstruction. Deliberately made a little bit longer because the fibula doesn't grow at the same rate as the ulna. And again, that can give a nice, good cosmetic result, good function, but again, it comes back, maintaining good surgical margins is absolutely essential in these patients. And you don't do these reconstructions unless you can get clearance of the tumour. We've also used fibulas at the distal end. This is a patient with Rothman-Thompson syndrome. These patients are at high risk of low-grade osteosarcomas. And the resection in this case is of the distal fibula and part of the tibia. And the reconstruction was done with a fibular transfer protected with a frame. This is what it looks like after the frame's been removed. And here's the reconstruction, and this is continuing to grow well at this stage and maintaining good function at the ankle joint using the articular cartilage of the fibula as the reconstruction. So I think we've got a great love for fibular grafts and using them in different places, but this depends on what your local skill set is and if you can work with a good plastic surgeon who's competent in raising these fibulas in an appropriate manner. So there are issues with fibular grafts. They're a limited resource. The maximum length in an adolescent is about 26 centimetres, so if we do one of our A-frame reconstructions, that means you can only get 12 centimetres. Normally these patients in an adolescent will be shortened by 6 centimetres. So that has to be planned into the reconstruction. Obtaining union, particularly in cortical bone, is difficult because these patients will start on post-operative chemotherapy soon afterwards, and that will decrease the healing capacity of that cortical junction. And there's a lot of soft tissue stripping that occurs when you make an A-frame type fibula. There's a graft stress reaction, and there are multiple fractures that can occur, and that's despite good healing and hypertrophy. We can be surprised that later on we do have stress fractures and deformity. And particularly this is a problem of load bearing. Here's a patient that had actually had osteofibrous dysplasia, had a large segment of osteofibrous dysplasia with recurrent problems with that, had that resected, a fibular graft, and you can see these are the typical fibular stress fractures that occur for many years afterwards. This is stabilised with a FD rod, but that then bent and another fracture, and eventually a customised nail, stepped customised nail, needed to be inserted to get that corrected and healed and properly supported in the end. So putting a fibula in there may not be the end of the story, and you may have to counsel the patients that this might be a course that can happen. What about allografts? Bridging allografts can include the metaphyseal region onto the physis, giving good stability and restoration of limb length. Fixation and healing is more reliable if you use intramedullary devices with allografts, but such constructs are prone to mechanical failure and infection and need to be careful. We can put an additional vascularised fibula graft in a trough, the Capana technique, and that improves healing and longevity of such constructs, but it's demanding surgery to perform, but it does give you stable fixation. And here's an example of an intercalary composite with a trough and a fibula and an allograft. More recently, this is a 4-year-old boy with a Ewing sarcoma with a skip lesion down in the metaphyseal region. This required a resection of subtotal resection of the femur to get clearance of the tumour. And in this case, we used a fibula graft, our favourite graft, with a allograft reconstruction, making a trough so you can revascularise that. And this allowed us to use the fibula as the replacement for the proximal femur in a 4-year-old. And so these can do quite well over the years as an alternative to what essentially would have been a hindquarter amputation. So osteoarticular allografts are applicable if a segmental joint resection can be safely performed, and there's multiple versions of these grafts. From fresh matched osteoarticular grafts and frozen irradiated osteoarticular grafts. But generally in paediatrics there's limited material you can obtain to do those. What about distraction osteosynthesis? Well, in our practice it's not widely used because of higher risk of infection, healing and deformity, and longer treatment times and greater stiffness of joints afterwards. This can be used in fine wire frames to stably hold small articular segments and provide additional stability when transarticular fixation is employed. And you can use combinations of acute shortening and lengthening or bone transport. But again, these treatment times are long, infections common, and the functional outcomes may not be as robust as other techniques. But you can look at these. The thing that has changed dramatically recently is development of intramedullary lengthening and transport devices. Our approach has been often to plan for calotasis as a second stage after healing has been obtained and the patients regain function when they're off the chemotherapy. So we avoid fixation for a bone transport or lengthening and utilise lengthening or transport intramedullary nails, and ideally after chemotherapy has been completed. This is an example of an 11-year-old with an osteosarcoma, had a reconstruction with an A-frame fibula graft. You can see that the limb is shortened by that 7.5 centimetres in this case. And then we've planned to come back and do in this case, a precise femoral lengthening to restore limb length and function. And you can see we've been doing this for quite a while with good success in coming back and using that approach. Now, with customised nails and the way things are changing, we can probably insert these nails as a primary fixation and use them as a sleeper nail to come back and do the lengthening. And that's probably where this area will change. So biological reconstruction, it's certainly more complex than prosthetic reconstruction. There are longer treatment times. But in paediatric practice, it's a very important part of our plan because these patients are going to be long-term survivors, and the reconstruction of the secondary reconstruction for prostheses is more complicated. It should be considered in a patient that appear to have a favourable response to chemotherapy. If it's an unfavourable response to chemotherapy and these patients may have evidence of local recurrence, you may need to change. You need a multidisciplinary approach and a well-coordinated team to do this. Thanks very much.